So hello, Brian, and hello, Dr. Sandrine and Dr. Kathy. So I was just telling Sandrine that you guys will be joining for the moderation, and I'll do a brief presentation, and we'll get the input from those who are in Cameroon who are joining us. So over to you, Brian.
No, thanks a lot, Mono, and thanks for choosing to speak on this topic. I think we've as I look back in retrospect, we've talked about some of the leading cancers in especially the killer disease. I think mostly we've talked a lot about lung cancer and the mortality that's associated with it. We've talked about colorectal cancer, which seems to be a big problem. One of the topics that haven't really been discussed, which is really rising in incidence in sub-Saharan African men, is prostate cancer. So I thought since last month was the global or the national Prostate Cancer Awareness Month, it'd be a great idea to discuss about the scale of the problem, discuss about the changing epidemiological dynamics of the problem, have some discussions on the situations in Cameroon. I think there'll be a urologist from Cameroon who will be joining us later today, maybe, and then maybe have an opportunity to discuss about the experience in Cameroon, what the underlying challenges are, whether it's in diagnostics, in screening, in management, or in research. Because again, we still have challenges with research, collecting sufficient data that would really inform how we tackle the problem. So it's really a great. Thanks a lot for the topic. I think it'll be a great discussion. And hi, Sandrine, it's great to co-moderate with you. I know I wasn't here for the last session, but it's great to co-moderate with you today.
Sandrine, I think you're muted.
Merci, Brian. Merci, Dr. Mono. Merci à tout le monde qui assiste à la session aujourd'hui. Je suis co-modératrice et je vais assister à la modération en français. Welcome, everyone, to this 110th session of the Cameroon Town Hall for Professionals. I'm going to be moderating today in French, and I'm very glad that we picked this subject. I was just telling Dr. Mono, j'ai parlé avec le Dr. Mono tout à l'heure et je mentionnais comment c'était assez courageux de parler du cancer de la prostate quand c'est le mois officiel du cancer du sein. Et il me faisait remarquer, comme Brian l'a si bien dit, que le cancer de la prostate est un peu négligé. Cela m'a fait penser au fait que c'est donc le bon moment pour nous de discuter du cancer de la prostate, puisque toutes les attentions sont tournées vers le cancer du sein. Alors, il y aura une bonne attention parce que quand on parle de cancer, c'est le bon mois pour parler de n'importe quel type de cancer. Il y a 2 semaines, nous avons parlé ici de la médecine de précision avec le docteur Kenji, je crois, qui était notre hôte. Et il a parlé de l'importance de l'accompagnement de ces diagnostics pour la médecine de précision. Particulièrement, on a parlé du cancer du sein, mais je pense qu'il y avait quelques mentions aussi de l'utilité que cette médecine peut apporter pour les cancers de la prostate. Alors aujourd'hui, nous avons le plaisir d'avoir des modérateurs qui sont des experts dans le sujet et nous espérons aussi savoir plus sur comment est-ce qu'on peut avancer la recherche et l'accès aux soins pour la prostate, le cancer de la prostate au Cameroun. Dr. Mono, please.
Thank you very much, and thank you everyone for joining us. And today we will, myself and the other co-moderators, we're going to bring up a very important topic and try to talk about it and see why this topic is important to talk about in the Cameroonian environment. And our goal is that we get other oncologists back home and urologists and also radiation oncologists and radiologists who are very pivotal in this particular cancer, which is the most prominent of all cancers in men. So I hope they get to join us and we really get to talk about this in a way which the layman can really understand why we are talking about this. So I did put up some few slides yesterday. There was an impromptu decision which Brian, with his ultimate wisdom, came about us trying to really get to discuss this topic. So I would like everyone, I presently, a lot of you who are here know me. I'm a medical oncologist by specialty, and I'm presently in Albuquerque. We have the biggest balloon festival starting today. For those of you who have never been to Albuquerque, it's a wonderful place. The whole city is going to be full with balloons. Albuquerque has 500,000 population. The metro area is about 1 million. It's not a small city. It's actually the 25th largest city in the US, but it's a big city with a small city mentality. That's how we joke about it. They don't want to be noticed. So we have the biggest balloon festival actually in the world that takes place every October. Those of you who want to come over, I can always house you guys. If you're coming over here, you let me know. Next October, just let me know. So I'm just wishing everyone a happy balloon festival here over in Albuquerque, where I am in the US. And it's important that today we get to, there are two quotes that are very vital to me. One of my patients told me this, I mixed them up together. And the last time she told me really in the office when she met me that life is 10% what happens to us. And I did understand why she said that, and 90% how we react to it. She had cancer and she was dying. She had anaplastic thyroid cancer, and I told her survivor was going to be less than 3 months. And she said she's going to make this 3 months the best 3 months of her life. And that really took me unaware. And she said, cancer cannot cripple love. It cannot shatter hopes. It cannot conquer the spirit. And she's not going to allow her spirit to be conquered. Last month was Prostate Cancer Awareness Month. We didn't talk about it much, and Brian brought this to my attention, and I thought, let's talk about it. Let's have a time to really discuss what prostate cancer is and why are we going to be talking about prostate cancer. This month is a very important month to me in particular. I am a big advocate of breast cancer. We've spoken about breast cancer in the town hall, I think more than 10 times. This same month, I have a series which I would organize on breast cancer education. Is geared towards nurses, doctors, residents, fellows, and also attendings who are treating breast cancer. I have a huge practice. Myself and my nurse practitioner, I think I see more than 30 cancer patients a day. So I have a lot of experience in cancer, and we'll be able to share what we can do for those patients. Now, I started with this figure because back home, I was a clinical pathologist in Cameroon, and I know that we have a problem when it comes to partnership, us deciding how we work. We need to work as a team. Prostate cancer is a team sport. It's not a single person sport that a urologist think they can do it in their office. And if you're not well trained in it, if you're not an on-call urologist, you'll not be able to do the right job. So prostate cancer needs the urologist. We need the radiation oncologist, which we are lacking back home in Cameroon a lot. We have a lot of need in this space. We need the medical oncologist, and we need other allied health professionals in order for us to be able to treat prostate cancer appropriately. Here is just a mark, just telling you those who are important in prostate cancer and where they stand. You have the urologist, usually those who have known metastatic disease, but you need to understand and really know why you think the patient has a known metastatic disease. For the urologists, it's important that we get initial diagnosis, and treatment usually comes from them, additional testing, surgery, which is prostatectomies, which can be done by the urologist, but they need to first of all do a biopsy and be able to tell us if the patient truly has prostate cancer or not. Radiologist, super important. Radiologists are important to get a staging workup when necessary and should not be neglected. MRI of the pelvis, which MRIs are very rare in a lot of regions, like the Northwest region has no MRI machine. I think the West has one, and the Southwest may, I don't know if they have one or not. I need to update myself. we don't have a PET scan, a PSMA PET scan, which is the most recent technology for imaging in prostate cancer. Now, the pathologist, this is our Achilles tendon back home. We need to be able to get biopsies sampled. We need to understand the futures, the patterns. Now, getting into what we're talking about 2 weeks ago, Kenjito spoke about the genomic testing, personalized medicine, or precision medicine in some of those cases. The pathologists help us in order to us, and those in the labs and the lab technicians, they do help us to get this done, and the scientists. Then you need the radiation oncologist. The radiation oncologist helps in biopsying, and what they do after the biopsy has been done is providing specific radiation therapy. There are different ways they can provide therapy, which we'll discuss. And you have myself and my colleagues, where we help in the medical therapy and hormonal therapy. We're actually involved in almost all the phases of treating patients with prostate cancer. So these are some of the different people. I have not mentioned some of the most important people you would have to deal with. In order to have a cancer center, you need support staff, you need patient advocate, you need genetic counselors, you need nutritionists, you need social workers, you need palliative care. You need all these people to come together for us to be able to do a good job back home. My real question is, are we doing a good job? So today I would go through a case which I actually had from Cameroon. This is a real case that I was called the family actually called me. And the reason I put up this case is for us to really discuss and see what will be our approach. This is a 73-year-old Cameroonian male with a past medical history of hypertension, presents with bilateral leg swelling, shortness of breath, lethargy, significant weight loss, urinary difficulties, and very severe anemia. He was needing transfusion all the time. And while he was in the hospital, lethargic, and they thought he was going to die, he had also AKI. Laboratory findings, someone decided to throw a PSA there. I think it was a young internist, throw a PSA there, and the PSA came back at undetectable. It was greater than 46,000. Now, my question is, how common is this situation in Cameroon? I think it's very common. If I, as an individual, have had more than 4 cases presented to me, I think it's a very common scenario. What is the most common cause of a PSA greater than 10? We'll look at another case. It's usually prostate cancer. Other things can cause it. Prostatitis from multiple causes, including just from atypical bacteria, TB, and other things. But you need to rule out a prostate cancer. What is the likelihood for this patient to have a newly diagnosed metastatic castration-sensitive prostate cancer? I think the likelihood is almost 100%. You cannot bet wrong on this one. And you just cannot bet wrong on this. What is the best treatment for this patient in Cameroon? I think all the best treatment is actually available. You'll be very surprised, but most of the time, a lot of the medical oncologists do not get to see these patients because they end up either with the primary care or they end up with the urologist. And at times, not everyone is up to date. This patient needs a medical oncologist, needs imaging, needs a biopsy, most likely not even a prostate biopsy because he has metastatic disease everywhere. And the reason this patient is anemic is because the whole bone marrow is full of cancer. So this just tells us Cameroon's situation when it comes to cancer is, this is the ranking of WHO. We're going to go over some of this data shortly. But cancer is a problem in Cameroon, not as big as a problem as malaria, because cancer, if you don't look for it, you will not find it. We need to be able to actually look for it in order for us to find the diagnosis of cancer that we are having. If we don't look, we're not going to see. Now, what are the most common cancers in Cameroon? When it comes to male, you understand why Brian insisted that we talk about prostate cancer, because prostate cancer is responsible for 25% of all cancers in males in Cameroon and is underdiagnosed. 1 out of every 8 men who lives, or even almost who lives up to the age of 75 is going to get prostate cancer. Females, the most common cancer is breast. That's why we talk about it all the time. And it's also as a result, the breast is an organ which is found out of the body. And if there is a mass there, we're going to always know. The third, when it comes to combining both sexes, breast is number 1, cervical cancer number 2, and prostate cancer number 3. And I think it's still underdiagnosed. When we look at Africa, we see the same trend. In Africa, what does the trend tell us? The most common cancer in Africa for men is prostate cancer. Most common cancer for women is still breast cancer. And Cameroon reflects the African data, breast, cervical, and prostate. So those are the most important. We have talked about cervical cancer before in the town hall, and we had a lot of gynecologists. We still have a need in that field. We need more gynecologists to be trained as gyn-oncologists so the patients get better management. And we need engagement and multidisciplinary teamwork. Now, what do we have as data in the rest of the world? In the rest of the world, lung cancer for men is still number 1, prostate number 2. In the next few years, I think prostate is going to be number 1. Breast is still number 1 for women. In terms of the US, where I work, prostate is number 1 cause of cancer in men, and breast is number 1 cause of cancer in women. So this reflects exactly what we see in Cameroon. And at times, the reason why this data changes is because Asia has a lot of population, and their frequency of prostate cancer is not as high as you find in Blacks when we start discussing the risk factors. Now, for mortality is the second cause of death in men from cancer. So you see why this is important. Here is the situation in Cameroon, and prostate cancer is still number 3. And here you can see also when divided in sex groups. So this is still the same data I'm insisting on. Now, Cameroon had a very ambitious, as usual, ambitious national strategy to plan for prevention of cancer. What I will tell you is that this was written, well-written data, but nothing was done. Here was a census at the time of our different specialists. I think this data from 2008, things have improved because now we train medical oncologists in Cameroon. We do train a lot of radiologists, pathologists. A lot of these specialties are trained in Cameroon. We had gynecologists, expert in oncology. There were 10 of them, but there was none who was a gyn-oncologist trained in fellowship at the time in Cameroon, unless someone wants to prove me wrong. So there are many things, and we didn't even have I don't know if we had a urologist who is subspecialized in uro-oncology back home, which is what we're going to be talking about. Here are some of the hospitals and availability of scans at the time. Things have improved since the African Nation Cup. There have been a lot of improvement in a lot of these hospitals. And I think even in the West region now, we have an MRI there. I hope it's still functional. So here are the cancer centers that actually do treat cancers in Cameroon. Nothing has really changed here. And you can see that a lot of those centers are also concentrated in the Northwest region. And because of this, you get to see the prevalence of cancer is high where people test and where people can treat patients. That's really what you get to see. Now, the Cameroon Oncology Center, they did do a presentation here. They're doing a great job. They have one of the best linear accelerators back home, and they're able to provide radiation therapy with good quality and excellent quality. So that's a place. This is not an advert. It's just for Cameroonians to know that this is available for them. Now, my next part of the discussion is to just get us to feel exactly what is done. This is another patient I got. I just want to know what everyone's opinion is going to be. This is a 69-year-old Cameroonian male retired general. Comes to see you. He actually saw a doctor. After an annual physical examination, he does not smoke cigarettes or drink alcohol. He's in the military. He explained he complains of some occasional dysuria, but is otherwise healthy and enjoys retired life with his wife. His original primary care doctor sent a prostate-specific antigen body, which came back at 7. Given his ongoing symptoms, he had a urinalysis done that was bland, but was started on a month of ciprofloxacin, okay? and for presumed prostatitis, which did not help his symptoms. He had a repeat PSA that was done after antibiotics, and his numbers came out at 13 nanogram per milliliter. Now, this guy was sent back home, and the question would be, what do we do next? I think the wise thing to do, which I told them to get, was for them to get a referral to a urologist for a discussion of prostate biopsy. He needed a prostate biopsy. So this is really what had to be done for this guy for us to know exactly where to go. Most likely, given a PSA of 13, he has early stage prostate cancer, and the fact that he had antibiotics and his PSA count actually kept rising. Here was another second case, which I heard that was presented to me also from Cameroon, a 55-year-old healthy Cameroonian male professor. The daughter is here in the US, comes to see you after a recent diagnosis of prostate cancer. His PSA was 47, increased from 12 2 years ago. Biopsy showed what we call a Gleason score of 9. That's actually high risk. And 5 out of 12 core biopsies were positive. This was done all at in Yaoundé and sent to Centre Pasteur. So they did a great job in actually telling us. Bone scan showed many lesions in his pelvis, his spine, his femur, and a bone biopsy confirmed metastatic disease of the prostate. What is the next course of action? This is very important because it really helps us to narrow how we're going to treat this patient. So I told them to give this patient androgen deprivation therapy plus abiraterone with docetaxel. All these drugs were available in Cameroon. They could have been expensive, but trust me, they were available. So he could get as better care as he would get in the US back home in Cameroon. Just needed to get the right person who can be able to monitor him while he gets his 6 cycles of docetaxel. So here is right diagnosis. Here is in the US, and here is actually my patient who came to see me and has an early stage prostate cancer. Here is an MRI, which I did, and I got his permission to share this, but he doesn't, his name is not here. It's an African-American male. He's obese, and he has multiple comorbidities. His performance status is very poor. So it's important. The most important thing about prostate cancer is starting from the base. We need to be able to diagnose these patients, get good pathology. There's something we call the Gleason score, which is Gleason actually. So the Gleason, you have the pattern, which tells us exactly what the grade of the cancer is. And how is that important? Prostate cancer is one of those cancers that patients can, those without metastatic disease can be from not doing anything to them, and their survival will be 20 years, to treating them very aggressively. So we do stratify patients, which I will not go into the details, since this is not a lecture for urologists or medical oncologists. But this is important, and your pathologist is supposed to be able to give you this data the way I have it here. If they are not able, like most pathology reports I get from Cameroon, then we need to start training and make sure we get the right data, because it's going to determine what we would do. For prostate cancer, here are the risk factors. And what is the most important? We're here, we are Africans, but I want to tell you guys, it's a sad story, but race, being an African is the biggest risk factor for prostate cancer. African ethnicity, they have the highest prevalence of prostate cancer with Ashkenazi Jews. So ethnicity and race, age, as we age is actually big. Age, race, geographic factor. We don't know why Asians, prostate cancer, especially in Chinese population and Japanese, is very low. Family history, genetic changes. We do have a lot of BRCA2. BRCA2 gene, those with Lynch syndrome, I found a lot of Cameroonians that I've met here who have Lynch syndrome. They never knew. They could never imagine they were going to have Lynch syndrome or BRCA gene positive. Diet, obesity, smoking, chemical exposure, inflammations of the prostate, those who have had repeated prostatitis, those who have had TB of the prostate, and sexually transmitted diseases is one of them. the reason I included this was just to talk about what we do, what the standard of care had been in the past. So before the World Health Organization and the US Task Force advocated for prostate screening for men greater than 45 years. Then later on, they said, oh no, we're screening a lot of men. And so we don't need to do that. But that led to us identifying prostate cancer early and treating, and this led to mortality change. You see here, the number of people who died actually reduced. But now we're getting a rise in the number of prostate cancer cases worldwide. So what will I advocate? For those who live in areas where you have high-risk populations like Blacks, you should screen them, please. Any male above the age of 45 should get a screening for prostate cancer, and you can do that annually just to see and then make decisions based on that. Here is a very medical-oriented flyer, which I will not explain everything. I'll explain some few things. As I said, those without metastatic disease in prostate cancer, the reason why we do biopsies and we are able to check for PSAs and stratify these patients, so you should send them to your urologist and to the medical oncologist if necessary for them to have this stratification done. Because there are patients who will have prostate cancer for almost 20 years and they are not going to progress and they don't need treatment. So those patients do not actually need any form of treatment, some of those patients. While there are patients who have very high-risk disease and they need to be treated immediately and they need to have staging workup for us to be sure that they do not have metastatic disease. So this is very important. So this is important and we need to be able to do that. Okay, so please just give me one. So when you talk about the rest of the treatments, we have multiple other things that we can really do for these patients after we have re-stratified them. Now, our workup for patients with prostate cancer really depends on where we are. Where we are in Cameroon, things get very complicated and education is very important. That's why I'm doing this presentation. The reason education is important is because we need to be able to tell which patients will need additional workup, which patients will need an MRI, which patients will need a PET scan, which we don't have available back home, which patients will need advanced imaging. So here is just a little bit of data to those who are data-oriented here, showing you that those who have very low-risk disease, if you do a prostatectomy or you do radiation therapy or you do monitoring, there is no change in mortality actually, which is very interesting. So for those with very low risk disease, you can monitor them for multiple years without inflicting any kind of side effects from the medications, but we need to know these patients. That's why we need these discussions. Now, when it comes to local therapy approaches, the reason I really want to talk about this, and there is one arm in this triangle which is totally almost absent. For patients with localized disease, we can do a prostatectomy. We can also do radiation, and we can do androgen deprivation therapy. These are the things we can do, and we can combine some of this therapy. I'll not pretend to be a urologist, but there are multiple urological techniques that can be used in order to help these patients out. So here in the US, we do a lot of robotic prostatectomies right now. You can do unilateral or bilateral neck sparing prostatectomy. You can do radical retropubic prostatectomy and pelvic lymph node. I personally, most of my patients do not get a prostatectomy. I would like to tell the urologists, actually, a lot of the urologists do refer patients to me, And we refer them to the radiation oncologist to get them do radiation. It's usually safer with less side effects, but it's a whole discussion. So here it tells you for those with early stage prostate cancer, they can also get radiation. Now, back home in Cameroon, how many centers can provide appropriate radiation, EBRT plus or minus lymph node radiation, affordably, cost-effective with little side effects? We still have the Cobalt machine, which is found in L'Hôpital General. It's an archaic machine with a lot of side effects. Now, the Cameroon Radiology Center is able to provide this, and we should be able to, and the problem also is going to be how expensive is this? Is it affordable compared to a prostatectomy? So usually the prostatectomy is the most affordable right now in Cameroon. So these are all things that we're going to talk about and see how we can improve and areas where we can invest in order to improve care in Cameroon. There are other salvage therapies such as cryotherapy, laser therapy, and resection, which can be done. So thermal cryotherapy, there are other forms of therapy which are available. Even in the US, I don't use this a lot. And cryotherapy can be used in patients who are very sick, cannot get appropriate radiation or surgery. High intensity focus ultrasound can also be done. These treatments are not for everyone. They're not for high-risk disease, and we should just know that they do exist. But that's not where I feel investment should be placed. Now, in summary, for patients who have localized prostate cancer, how do we take care of them back home? How can we improve things? What is being done? I know back home, I did talk to a few urologists before, and I know we are able to do prostatectomies even when I was in Cameroon as a GP, assisted in a lot of them. And re-stratification is important. We should just know the right patient who deserves a prostatectomy. Please do not do a prostatectomy for someone with a PSA of 65 without doing staging workup. Workup has evolved with imaging, genomics, and many other dynamic studies. We need to be able to do workup for those who have high PSA and those who come in with symptoms which are systematic. Active surveillance is reasonable in patients who have low-risk disease or very low-risk disease. Surgical resection, radiation are the mainstay of localized treatment. Multidisciplinary approach is important. Anyone with moderate risk comes to the medical oncologist, even with localized disease, and we give them androgen deprivation therapy. Now, after you have treated these patients, what do you need to do? The GP doctors need to know. Our nurse practitioners need to know what's the definition of someone who has a reoccurrence. It's usually someone who has had a surgical prostatectomy and then they have an increase in their PSA of greater than 0.1, or someone who has had radiation and their PSA is doubling. So it's very important for us we go back to Kenji's slides here, which tell us about personalized therapy. Personalized means each individual can be treated appropriately. We can actually observe a lot of these patients and not treat them, and nothing is going to happen to them. We should be able to know the patients to observe. Patients can actually get adjuvant radiation therapy, but this is rare in Cameroon. It's expensive. There is salvage radiation. There are times we join radiation plus androgen deprivation therapy, and we give androgen deprivation therapy alone also. Now, why do we even treat prostate cancer the way we do? There is one thing I wanted to talk about. We don't do it in the US. We don't do ochiectomies in the US, but it's still practiced in a lot of European and Eastern European countries and in Africa. Why? By taking out the testes, you're able to control metastatic prostate cancer. So this is what is important, those who are here. For patients with metastatic prostate cancer, you're not able to afford androgen deprivation therapy, you can castrate them. So you can take out the testes. That's an ochiectomy. Now, once you do that, you deprive the glands from testosterone that they use in order to grow, and most patients can get into a remission for a few years. But the prostate itself escape coming from these organs, and these patients usually reoccur. But that's still part of the standard of care, and that's what is still being practiced. So it's something that we should think about in our environment for those who are poor and be able to explain to them. Let's not do prostatectomies to patients who have metastatic disease or we're suspecting they have metastatic disease. It's very important. I know there is NACO, but we should be very careful. Now we have used the drugs we do use is something called Luprolide. It's available in Cameroon. And also in Bingo, they do have Relugolix, which is available. These are the drugs that we have used, and you can see how effective they are in controlling. Even in metastatic or non-metastatic and high-risk patients, we do use this in order to help in the treatment, the medical oncologist. So here I am just trying to explain that in patients who have reoccurrence, we have certain drugs that we are using right now in order to treat these patients. And these medications actually do block the production of testosterone at the level of the adrenal gland. There are drugs like enzalutamide, apalutamide, abiraterone, and we have abiraterone in Cameroon. It's available. I've had multiple patients being put on abiraterone, and it's just important that we get this information out there and we're able to educate people so that patients can have access to this and be treated appropriately. So if you have your patient in Cameroon and you don't know what to do with metastatic prostate cancer, I'm not advertising, but Bingo does a great job. Those who are in Yaoundé and other cancer centers, you will let me know if you guys are able to have access to these medications, how affordable they are. But Bingo does a wonderful job in order to treat these patients. Now, we do have issues back home. There is an important scan that was discovered in Germany. It's called a PSMA PET scan, which is actually done in order to identify cancer that we used to think those who had reoccurrence, what we call a hormonal escape, but they actually do have disease that it's not sensitive for us to identify. And this is also part of a treatment algorithm that we give patients. Here you can see this is a PET, those who have never had a PET scan, this is a PET scan. Here you see lesions that are lighting up with bone metastasis that this patient has. And we can pick it up on a regular PSMA PET scan, but all other imaging in this patient, who was my patient, was negative. So these are the innovations that we want Cameroonians and others to go home and let's invest in healthcare. Now, for those who have increase in PSA while you were on hormonal treatment, by doing a PSMA PET scan, we can identify oligometastatic disease. We can do radiation to those areas. We can modify treatment in different ways. And that's the second reason why we need to really invest in other forms of treatment like radiotherapy. And I think the government needs to really step in here because it's very expensive, but there's a private sector. I think Bingo is going to they have a radiation oncologist who was trained in Dr. Tunsi, who was trained in South Africa, and I think they'll get a linear accelerator and they'll be able to do this back in Bingo. L'Hôpital General has in Douala do have a radiation oncologist. There is Dr. Mason who is there, and there are others who are there, and they are able to, they just need to upgrade their machines and be able, I think the Cameroon government needs to invest in doing that. And all 10 regions really need radiation therapy, not only for prostate cancer, but for multiple other cancers. Now, just for patients who have reoccurrence while you have done surgery on them, what can we do? We call it biochemical failure, defined in a variety of ways, and the young doctors need to know why we define that. We have personalized options. Patients need to be sent out, and we need to also do certain tests in order to see, but some of those tests cannot be done back home. We do have options for PSA-only disease that we can actually treat these patients. We have enhanced imaging, which is not available back home, and we have treatment for oligometastatic disease. And this is very important. Here is, for the sake of time, I'm going to be very brief. Here is one of my patients who came and saw me too. He had 81-year-old gentleman with a history of prostate cancer, lesion of 4+3, which was 7, who presented with me after being discharged from the hospital. If you look at his history, in 2005, after a urinary symptom, he had an obstruction, and he had never had a prostate cancer screening. He did have a diagnosis of prostate cancer. He declined surgery at the time, wanted radiation, got one session of radiation and disappeared. Just one fraction. He was supposed to get 35 sessions and he disappeared. He deferred treatment for further due to side effects, and now he came to see us in the hospital. He was hospitalized for 1 month, and now he has metastatic disease. This is actually his bone scan showing you multiple disease everywhere. Here are the treatment options you can give these patients with metastatic disease. I will not go into the fine details of it because we are not doing an oncology lecture here, but I just want to show you that a lot of these things are available in Cameroon. When we talk about treatments, I would start with hormonal therapy. The basic treatment for prostate cancer is hormonal therapy. Enzalutamide, you can get it in Cameroon, but it's expensive. Apalutamide, you can get it, it's expensive. Darolutamide, you can get it, it's expensive. But you can get abiraterone, it's generic right now, it's cheap. You can get someone even get it from you from Europe. They are very affordable, and it's now generic and it's cheap. We also have drugs like Luprolide, Lupron, and which we can get, and GnRH regulators and anti-androgen therapies like Casodex. We can get all those medications can be gotten in Cameroon, and there is no excuse. The problem is knowledge, knowing that these patients need this medication. Secondly, cytotoxic therapy. Docetaxel is found in almost all chemotherapy centers. It's an old drug, more than 50 years in existence. Cabazitaxel may be rare, not found everywhere, but carboplatinum can also be found in Cameroon. So these are things that we have. Now, we do not test for MSI high, so we are not able to give immunotherapy in these patients. Supulisol T cannot be given in Cameroon. We don't have it. Radium can be given by the radiation oncologist if they do have a good radiation center. We can actually have access to PARP inhibitors here, but we don't test for BRCA genes. So those are the things that are available. The question is, are we able to know that these are treatment options that are found? We do have lutetium-177, which is a new treatment and still very sparingly used even in Europe. It's accessible in the US. Here is just a group of clinical trials showing you exactly how we treat prostate cancer right now. I'm not going to go into all of this, but right now with those who have metastatic disease, there are multiple options on how we can treat them. We can use androgen deprivation therapy and combine it with adrenal blockers. There are 4 of them. They are all approved. The most recent data is adding, which we call the PEACE-1 trial, and there's also the ARISET trial that added docetaxel 6 cycles to this treatment, and these patients have an amazing response. Can we do this in Cameroon? Yes. Have we been doing this in Cameroon? No. Can we orientate patients to get the best care? So far, I have worked with a series of physicians back home, and I think Bingo is able to do abiraterone, docetaxel, and ADT, and they have it as part of their protocol. So those who have patients who are really sick and progressing, please reach out to Dr. Tutsi and also reach out to those who are there at Bingo, the oncologist there, and they will be able to help you out. Here is 2024, the standard of care, what we call the NCCN guidelines. I'll just keep it here. I don't want to go over this, but it just tells you how we treat metastatic disease. And the sad fact about Cameroon is that almost 70% of all our prostate cancers are diagnosed in the metastatic setting. These are patients who come in with a back pain, who come in with continuous joint pains everywhere and nobody really knows what is going on, and they do a PSA. I have a friend who called me for the dad just recently. His PSA also was above 5,000. They could not read it because they were not doing a quantitative PSA back in at the regional hospital. So here are all the different trials that show that these medications do work. Here is a line of research that has gone up for years that show you exactly why we do things the way we do them. Now, in a big nutshell, how do we do with prostate cancer? Patients who have non-metastatic prostate cancer, most of the time, the treatment and their low to moderate risk will stay with the urologist. Those who have metastatic or those who have high-risk disease need to see a medical oncologist or need to see a uro-oncologist. Radiation discourage most of my patients from getting surgery. Majority of them get radiation therapy and they do fine. And they have little side effects from the radiation itself. And that's my preferred treatment. All treatment options are available, but that's my preferred treatment. So a lot of the patients are referred to me by urologists. They end up getting radiation rather than prostatectomies. And they do fine. Survival is the same. Outcomes are the same. Now, the reason why we do precision medicine here too is because a lot of Africans are BRCA2 positive, but they don't know. So in terms of genetic alteration, there are certain genes that are responsible for you having prostate cancer, such as the BRCA2 gene, the ATM gene, the CheckMate2, and the BRCA1. So these are all things that we need to invest, train more genetic counselors, get ourselves. We have the equipment already. As Kenji told you, we just need to use them rightly in order for us to test these patients. Here, I did throw in one of the studies where we use a drug called olaparib for those who have progressed, and we're able to actually help them, salvage them, those who are actually progressing. So there are multiple other things that we can do. There are multiple other trials. This is really the last thing in terms of innovation. When it comes to prostate cancer right now, we have the PSMA scan, which is not available back home. I hope we can get scans available home, and the PSMA is just a marker that we can use in order to pick up cancer in the early stages and also to pick up metastatic disease and treat patients with lutetium-177. Here was the clinical trial, which I will not spend time on. Another thing I want to talk about, which is always neglected, is bone health. Bone health is very important with patients who have metastatic prostate cancer. Why is bone health important? If you have someone who has metastatic disease, we do need bone reabsorption medications in order to protect their bones. This actually improves mortality. We do have alendronic acid in Cameroon. We have pomodoronic acid, maybe zoledronic acid also. These are all, some of them are relatively cheap, and you can actually help these patients with metastatic breast cancer, prostate cancer. Those two cancers love the bones, and that's where they go to first. Denosumab can be expensive, which is Axchiver, and it's not yet generic, or Prolia, but it's important that anyone who is treating cancer should recall and should know about this. And this is going to be a saver for both our patients and everyone else. So this is really something I always want us to think about each time we're dealing with cancers. Here is take-home message is we should be able to identify and stratify prostate cancer patients. Is it a public health problem in Cameroon? I showed you it is. It's the most common cause of cancer among men in Cameroon. Every one of you here has a family member who has prostate cancer. You may not know about it, an uncle, a dad, a grandfather, or somebody. They should go do their PSA. You'll be very shocked. Every one of you here has one. Now, those who have metastatic disease, we should be able to get them to the right doctors, train our doctors appropriately so these patients can get medications that are available. We are not talking about things that are not available, that are available in Cameroon that can help these patients. For those with metastatic disease, we should think about protecting their bones. They should be on vitamin D and calcium. They should also be on bone reabsorption medications in order to help protect them. We should continue advocating for investment, both from the government and from the diaspora. What are the things we need to invest on? I think we need to invest on pathology, very important, so that the pathologists will be able to identify and stage these patients and grade them appropriately so we can treat them. We need to invest on subspecialties. The urologists we train, we should be able to also send them out to train as uro-oncologists, not only for prostate cancer, bladder cancer, renal cancer. They will do a great job helping these patients. We should invest in our medical oncologists, in training them. It's very difficult to train a medical oncologist appropriately when in a country where you don't have access to radiation therapy. They will train and they will not know the importance of a radiation oncologist because that's not how they were trained. They should be able to have collaboration among ourselves. So collaboration is important. And the reason why collaboration is important is that there is no field like medical oncology where you're able to see the importance of collaboration. You cannot treat a single cancer alone. You cannot. You cannot claim you can do that. And usually you have multiple other people. You need radiologists who will be able to help you with biopsies, and they can be able to train interventional radiologists that will help us with certain biopsies, easy biopsies without killing patients. We need to train our medical oncologists to be able to use these medications and know when they need the help of other subspecialties. I cannot deal without my radiation oncologist. There is no time. We bounce cases from between each other. I never take the urologist out of the picture for any patient with, even with metastatic prostate cancer. I would need them later on if there is incontinence, if there is a lot of complications happen. We need them. So it's a team sport. It's not a single person sport that you think you can sit in your silo and make money. That's not how cancer works. So this week is actually Breast Cancer Month. And I think I will be doing a series on breast cancer lectures. This is going to be out of the town hall, but on the 26th and the 27th, we'll talk about breast cancer. It's geared for more for the medical specialists and also for physicians, for nurse practitioners, for scientists, so that we can talk a little bit more about breast cancer, give education, and we'll try to see if we can get CME credits for that. Here is the last patient I put in. This is not a patient back home in Cameroon, just showing you what we do for some of these patients. This is my patient. He's a 65-year-old man with a family history of prostate cancer, presents with intermittent left hip pain. Workup was notable for prostate nodule on the rectal exams, which the urologist did, not me. He is noted to have a PSA of 116. He had a TERP biopsy that showed a Gleason of 5+4, which is high risk. He's a group 5, and 10 out of 12 calls were all positive. Several left pelvic lesions were noted on the scan, on his bone scan, with retroperitoneal nodes on the CT abdomen and pelvis. Biopsy of the bone confirmed metastatic disease. Genetic testing, which is germline and somatic testing, was negative for BRCA. So then how did I treat him? He was treated as hormone-sensitive prostate cancer with triple therapy. He's a very unfortunate guy. But I gave him Lupron, Abiraterone, and docetaxel. I expected it to work for many months. He got 6 cycles. 6 months after initiation of therapy, he has undetectable prostate PSA, and patient is asymptomatic. Now I've been following him up. Unfortunately, the patient does not return for regular follow-ups and comes to see me 2 years. So this was done by my colleague. I see him 2 years now. He has widespread metastatic disease in the lymph node, in the liver, and in the bones. He notes he did not try any additional oral therapy. He was prescribed enzalutamide, which he refused taking. The next question is, how do I treat this guy? Now I did a PSMA, a PSA, it was 76, and I did a PSMA PET scan, it was positive. So what I did was I actually offered this guy to go back to the radiation oncologist and get a lutetium PSMA treatment. And he did absolutely well. I'm going back to my initial point, which is Achilles tendon in Cameroon. Is really where our biggest problem is, learning to work as a group. In order for us to progress in the field of cancer, in order for us to progress in treating cancers, this is my last slide, I think we need the input of a urologist. I think the urologists need to understand that they do not understand all these drugs very well, and they are not treating these cancers very often. They need to collaborate with the medical oncologist. And I think the radiation oncologists need to get involved. We need to train more of them. We need to do both government and private, including palliative care. I cannot work without the palliative care team, including nurse navigators, social workers. We need also spiritual support. We need physical therapists. We need everyone in order to get the best outcome out of healthcare. Difficult roads can lead to beautiful destinations. That's what I would always tell people. There's nothing which we cannot do. We are here in for a difficult road, but there is a destination ahead for all cancers in Cameroon, including prostate cancer. So prevention is better than cure. Now, how do I tell you to prevent prostate cancer? Primary prevention, there is none. Being a man is the risk factor, but secondary prevention, there is a controversy about doing PSA, but we are living in Cameroon. We have a Black population. The biggest risk factor after age for prostate cancer is race, being Black. And so we should screen everyone above the age of 45. So thank you all, and over to you, Sandrine, Dr. Sandrine, and Brian.
Yeah, thanks, Dr. Mono, and thanks for really giving an excellent presentation. When I saw your last slide, the slide where you showed how much the management of prostate cancer is so multidisciplinary with the need, radiation oncology, I was asking myself how many of those do we even have, in our context, even pathologists and I think significant. And I think the situation we have in Cameroon closely mirrors the experience of other African countries as well. So it was kind of reminding me of the real challenge. And that particular case study that you gave at the beginning, I think you said one of the patients that was referred to you from Cameroon that you looked at really highlights the realities of the challenge, late diagnosis in prostate cancer, and the challenges with just resources to diagnose the disease early on. So I think that was a really that really summarized the core tenets of the problem that we have. So thanks for giving us a really excellent presentation. I see that Kathy has joined us, and also just wanted to hear a word from him as well, and Dr. Matt Polo.
Merci, Brian. Thank you, Dr. Mono. This was very there are people who can live with prostate cancer and do not require treatment. Ce qui est important, c'est que cette présentation nous a donné en fait un aperçu global de comment prévenir le cancer de la prostate, quels sont les facteurs de risque, mais surtout aussi que le traitement n'est pas toujours nécessaire dans des cas de cancer de la prostate. Alors, je ne vais pas prendre beaucoup de temps, je vais laisser la place aux questions et certainement on aura une discussion intéressante. Je ne sais pas si c'est le professeur Kate qui prend la main ou Franklin Maloba qui a la main déjà levée.
Je voulais juste que peut-être, je ne sais pas si Kate, are you able to speak, Kate? Maybe we lost him. Yeah. Yeah. So I think we can. So if you have any questions, I think in reminiscence for the National World Cancer Day, and one of the tenets during the discussion was how do we increase awareness for prostate cancer diagnosis. If you have any questions about that and things that can actually be done, I think it would be really great to have those discussions here and also mobilize resources that can help in surveillance purposes, and that was the central theme during the National Prostate Cancer Awareness Month. So if you have any questions, please feel free to raise your hand, or you can use the chat feature to drop those questions as well. Franklin, over to you.
Yeah, good morning, the town hall. Good morning, Brian, and good morning, Dr. Poma, for this excellent presentation. Yeah, I think that listening to you, I realize that prostate cancer is really a major concern. Yeah, but I know the first question I'll ask is, over the social media, there's this thing that's spread out and that is spreading everywhere, that having sex reduces the risk of prostate cancer. Some people say having sex 3 times a week and men are happy all over the group. So does having sex has anything to reduce the risk of prostate cancer? Yeah, that's the first question. The second question is, what exactly can we tell someone in my village who don't have the money or the resources? What should he do in order to reduce having the risk of prostate cancer? And the final question is, what genes are there in Black that are different or that makes us different from maybe the Asian that that exposes us a lot to prostate cancer? Yeah, thank you.
Wow. So, Malober, thank you for that wonderful set of questions. I will start with the last question. I'm going to take from the last going up. Now, in terms of genetics, in Africa, we've had very few genetic testing that has been done, but we're getting to realize that a lot of Africans do have the BRCA2 mutation. That's one. There are other checkmate mutations that are there, which we see. If you don't test something, you will never know that you actually do have it. So majority of the time is just because of the lack of testing. But what we have realized is that among the few Africans that we do have, especially here in the US, BRCA2 mutation is quite frequent. ATM mutation is frequent. The CHEK2, what we call CHEK2 mutations are frequent. There's PARBIT2 mutations, which are frequent. And there are other mutations that you do see among Africans that you don't see in others. The second thing is, actually, at times, it's not even the mutations itself. It's more of, we are still figuring out. But what drew our attention to this is that among African Americans, the incidence and prevalence of prostate cancer is higher. There could be some other protecting genes that we find in Asians, so there is still a lot of research going on. So it's not only about deleterious genes, but there are also others who have protection genes that actually protect them from actually having this. But data that we know strongly suggests that age is number 1 risk factor for prostate cancer. Number 2 risk factor is number 1 is being a man. Women will never have it, so they don't have a prostate, okay? Number 2 being age. As you age, you get prostate cancer. We joke about it that if you do a biopsy for every man who lives up to the age of maybe 90, you'll find out that maybe there is a prostate cancer or there's benign prostate hypertrophy. Now, why Blacks? We have an observational data. We need a lot of research. We need a lot of you guys who are researchers in your core to go back home in Africa and let's figure it why. We thought it was just in Americas, but now that we go back home and we're having a high life expectancy, we're tending to see that we have more people back home who have prostate cancer. There was another theory, because you do have anything that causes inflammation in the prostate, repeated urinary tract infections, also inflammation. Those who have TB of the prostate, those who have tuberculosis and other things also increases the risk. Anything that causes the prostate to inflame and increases the risk of prostate cancer, but that alone does not suggest that it's actually what explains that. The second question is, what do you tell the papa in the village?
I just wanted to expand on that. When you said that Asians have more protective genes, because you presented harmful genes that have been identified in sub-Saharan Africans. So what are some of those protective genes that you've seen in the literature for Southeast Asians that prevent them from having a higher incidence in prostate cancer? I just wanted to hang on that.
No, that's where I said we need data. There is no real much data out there. We need data. Genetics is difficult to analyze. It's easy to find a deleterious gene, but it's difficult. That's why I said it's more of a hypothesis.
Okay.
I would just add to this, if you look at sickle cell disease, you also have these protective genes phenomena. If you have people with beta tal and persistent fetal hemoglobin, and they have sickle cell disease, you'll see that they are less anemic, less sick. And Dr. Mono can add to this. This is not particular to cancer, but there are certain situations where you have a particular population which is somehow protected because they are a protected gene, or they are absence of certain genes which actually populate the phenotype or the endotype that we're saying.
Yeah, so thanks for that question. I think it's a big place for research. Sickle cell has done a lot of research in that field. You can actually get, and it also, there are things we don't talk about, like in sickle cell, the haplotypes, the haplogenes themselves, the different types, the different subgroups, those who have the Cameroonese, the Bantu, and all of that. But for prostate, Brian, I don't know yet. That's something I need to do a research and figure out really in Asians, do we have that documented? But those are all things that could happen. But in Africans, there is still a lot of research going on to identify why Africans have more prostate cancer, and even why Blacks. A lot of those who have been studied are actually Black Americans who migrated from Africa. But we are getting to realize that if you go throughout all African countries, the number 1 cause of cancer is prostate. You go to Asia, it's not number 1. It's not even number 2. At times, it's not even number 3. So you get a shock. That's evidence that is out there shining at your eyes. You need to figure out why. Caucasians are in the middle. We get a lot of prostate cancer among Caucasians. And their cancer tends not to be as aggressive as Blacks. Most Blacks I get already have metastatic disease, even in the US. There is also the social determinants of health that could explain that, as you know, which a lot of them lack access. So we need to piece out what is causing what. Now, the second thing is...
Yeah, please, before you continue, what about métis, like hybrids?
No, we don't have data on that. We have not even studied the Blacks. So
now I was just trying to see in case that neutralize a bit, like to see if I don't know if it's okay.
It's true. It's a wonderful question, but we have not even studied the Blacks. Then we're not even coming into the point of studying the mixed races, because most of the time they are all jumped into Blacks. The way they are classified in America, once you're a mixed race, you are never called a mixed race. You are classified as Black. So there is no data that really identifies them and wants to study them. Maybe in Brazil, where there are several groups and castes, and in South Africa, you may be able to get those studies done, but it's an encouragement to look at it. We're expecting, like any other genetic variation, that there are some things will protect others.
Yeah, now, because these are heterozygotes. So hetero, I don't know if heteros may also neutralize the effect. Yeah.
Yeah, your sound, Dr. Mono.
You guys get me now?
Yes.
My internet has a problem. It's weak. So color genes, it's a heterozygote. It's more of it's what we call a complex gene. So the way people inherit color and the height is a bit complex. More than that is something we can talk about in genetics, but it's a bit complex. You may get, that's why some kids are Black, others are more lighter. So because you get more genes from the mom or the dad, depending. Now, going to your second question. What do I tell the woman who is in Furawa, who is in Jikwa, who is in Chwerere, the man, sorry, and the family, that what do you do to reduce your risk?
We lost you again, Dr. Mono. The sound. Yeah, we still can hear you. You're muted now.
Okay. Can you hear me now?
Yes.
Okay, this is new, but coming from my internet, most likely. So it's one of those things where not all cancers have a clear-cut cause and effect. Not all cancers do have a clear-cut cause and effect. For prostate cancer, the modifiable risk factors are very few. So primary prevention is a very difficult thing to do. Secondary prevention is where we should lay a lot of emphasis. Why? Because we are not going to be able to change your gender from being a man. We are not going to be able to change you from aging, which are the main risk factors, and we cannot change your genes. Can we prevent you from having multiple sexually transmitted illnesses? Yes. Can we prevent you from having tuberculosis of the prostate? Yes. Can we reduce your alcohol intake and smoking? Yes. Those are all general factors that have shown that they improve the risk or they reduce the risk of you having prostate cancer, but the relative risk of that is very low. So overall, is what we do, we need to systematically screen. It's a controversial topic, but I think in Africa it's not controversial. Anyone who is above the age of 45, get them a PSA once a year when they come for their regular checkup so that we can identify it early, and then we can treat them early and get them the best care they need. Now, the first question, which I kept for
Just wanted to hang on that first question, that second question that he asked on screening. Is it accessible, especially at the rural and peripheral level, to have access to PCA screening? Because one of the second aspect of his second question was this aspect of screening, and I'm kind of curious how, in terms of cost, how easy or difficult it is to quantify PSA levels in Fulani, for example.
Yeah, so let me give you this. If you've ever, I was a district medical officer in Cameroon, so I know the prices of those things.
Dr. Samuel might have also an insight. I see his camera is on.
Yeah, so there is, in Cameroon, there is point of care PSA, okay? And also working as a clinical pathologist in Cameroon. So there's quantitative and qualitative PSA tests that can be done. And some of them are not, they are semi-qualitative and semi-quantitative. The what we use is semi-quantitative. They are very affordable. And we can actually do PSA screening in all district hospitals and even health centers. You don't need much. Most of those tests are actually qualitative, semi-quantitative tests that you can get them done. They are very easy to do. Right now, there are point of care tests that can be done for PSA. The question becomes, should you screen for PSA? That has been a debate. But that's a debate that is losing its track even in the US. We realize, let me just give you guys this. For the past 10 years, which we have not been screening for prostate cancer, the number of cases of metastatic prostate cancer have increased. Mortality for prostate cancer has increased. And the US task force, which was the one who actually, the United States task force decides the public health regulations. Then the American Association of Oncologists, we have our own regulation, we should screen. The urologists think we should screen. And now the task force in the next few years is going to change their recommendations, given that we are having more cases of patients with advanced disease, and the rate of prostate cancer, which has been declining since the early 90s, is increasing. And why is it increasing? Because we're not screening and a lot of patients are not being tracked. We find them only with metastatic disease. So going back to Africa and to Cameroon, where we are all Blacks, our risk of prostate cancer is high. I think we should screen everyone above the age of 45. Easy screening, get it once a year or once every 2 years. Just know what the level is and know how to interpret it, because that's why I said PSA greater than 10 should be what should be really the goal. Anything less than 10 could be prostatitis, could be a patient who has TB of the prostate, could be any inflammation that you're having, even a UTI can cause that. Even naturally, you could have a PSA which is still above 6, but you need to be careful on how we interpret it and train local solutions for local problems. Now, going to Maloba's very important question. Maloba, yes, there is data. There is data which is controversial. There is data that shows that increased ejaculation, increased sexual activity may decrease your risk for having prostate cancer and increase your risk for having benign prostate hypertrophy. Why is it controversial? It's just that, however, this was published in the European Urology Association journal. That was published in 2016. That's what this track came about. It has not been replicated anywhere. We don't have any prospective data, clinical trials on this, because it's difficult to do a clinical trial and 10 men to have sex this number of times. So it's something which is out there. We talk about it, but there are other ways and there are other factors that are more prominent. It's just like the sexually transmitted diseases that we have there that can increase your risk. But there is data, but the level of evidence is not a level A, B, but it's a level C evidence.
Yeah, because the question I asked that because I was thinking that way, but I know a lot of polygamous men, maybe polygamy doesn't necessarily mean number of sex you have, but many of them have prostate cancer instead. You are muted. You are muted. Yeah, we don't get you. Sorry.
Can you guys get me now?
Yes.
I say you cannot say that, because what is happening is what you're saying is purely, it's just out of your personal observation, but there is no data really stating that polygamous men have more prostate cancer. Maybe polygamous men, there's confounders in it, could be living longer. Who knows? Maybe they have multiple women, they live longer, and then you tend to see prostate cancer. But majority of Africans and the past that you know, and those who have lived, a lot of them were polygamous. But it doesn't mean that polygamous men get more prostate cancer. And you're still having the young generation, which is still aging. It's now in Africa that we're getting into the field of not practicing polygamy. So majority of those back home are actually polygamous. So there is no data really showing that polygamous men get more prostate cancer. There's none. It doesn't exist.
No, I was not saying that they have. I was just saying that I see them also having it. You know, many of them having it. Like that was just, yeah, base. Okay, I got you. Yeah.
I think this is very interesting. We're going to follow up on this. We're going to pass on the mic to Dr. Samuel, who has his hand raised.
Thank you very much, Dr. Sandrine. I wanted to follow up on I know Dr. Brian and Maluba follow up on the question about those living in rural areas and in villages. I wanted to pick example for us in DOP. We actually had a group, we started with men because we have a very powerful women's group. And to Brian's point, it's difficult to find a man just come for a checkup unless they are coming because something is wrong. So when we actually talk about going for annual checkup or wellness checkup, unless they, from Dr. Mono's presentation, the education is very, very crucial. For the 5 years that we have been in existence, we started a men's group trying to encourage them, but it failed. But with the women's group, because many of them are of childbearing, they do come they do come every month. But so you would not even find a man that will be willing to come unless they're sick for something else that you will have them come. But I think the idea about education, we training more community health workers and having to talk to many men, those that we have actually had them come is because they have pain, joint pain. And so it is very difficult to even get into that point unless they have already gotten to the point where maybe just through different labs, you happen, just like in one of your presentation, I think it was an accidental lab that they did a PSA. So that part of screening is completely, for most of our general practitioners, I don't even think that it is something in most rural areas that they even think of that we have to be doing that screening. So I just wanted to add that point on.
I will add to this also. I think this is really an interesting point that men who are sick do not seek care. They rather wait until the last minute to actually look for help. Perhaps this is also a way we talked about the importance of having a multi-collaborative approach where a lot of caregivers and providers actually concentrate around the patient. So the first physician to see those men perhaps will be the first physician to request for a lab test, a PSA test, the rheumatologist, the GPs, or even the cardiologists when they go for those who have hypertension. Perhaps those people should also be part of this discussion because they are the first responders when men have problems like pain.
Yeah, and Sandrine, we have it's a problem not only in Africa. Generally, men neglect their health.
Yeah. I've seen some great ad from pharmaceutical companies in Latin America, because this is also the case. I think this probably may be a man issue worldwide. So they found out if you go to the daughter-in-law, they actually have campaigns at daughter-in-laws. So they are the one actually, they have the confidence of the father-in-law. So if you go through them, you might actually get to the man in the family, and he might be willing to go and get tested. So maybe we should have, I don't know, colleagues from behavioral psychology here to help us get to those men, to their relatives.
Yeah, generally men think they are stronger. They think they don't get to the hospital for regular checkups. Even in the US, it's very clear. Majority of the time, you find more advanced disease in men. And that's why male mortality is higher. Apart from the risk that men don't live as long as women. Men seek care later, and men seek emergency later. So, and same thing is going to happen in Africa. I think if we can get to educate our frontline health workers to at least screen for prostate cancer, majority of the time, the cases that have come to me are because someone had a bone pain and someone thought this could be prostate cancer. Someone went to the hospital for something else, like the case that I presented was anemia. And then after trying to figure out what is going on, someone did a bone marrow and the pathologist told them it's prostate cancer. Then they did a PSA and they found that the PSA was high actually. I didn't go into the detail of all the case, but you get to realize that at times we don't really think about certain things, but those are basic things that are, and there is underdiagnosis of prostate cancer in our environment. Truly, the amount of prostate cancer is not reflected in the statistics that we have in Cameroon.
I think there are two questions in the chat. One is by Irene. La question, c'est à propos de savoir si l'option d'enlever les testicules n'est pas présente pour les patients qui ont des cancers métastatiques. Quelles sont les options pratiques pour le traitement du cancer métastatique dans le contexte, j'imagine ici le contexte africain?
Ça, c'est une très bonne question. And what I would say is that we can do orchiectomies in Cameroon, or orchidectomies. We can do them in Cameroon, and it's a valid treatment option. Valid. The problem I find is that I find a lot of patients getting prostatectomies, which may be a more expensive surgery, and not getting orchiectomies because nobody has the courage to tell them, I want to take out your testes, I'm castrating you. Nobody has the courage, and people pretend and go do prostatectomies, which are useless in those patients. Why? Because orchiectomies are actually standard of care still by WHO to treat patients with newly diagnosed metastatic prostate cancer. You take away the testosterone that is feeding the cancer. The only thing is that in the next 2 or 3 years, the patients will progress. Why would they progress? Because you have other organs that produce testosterone. Your adrenals actually do produce testosterone. In the adrenal, there are sectors in the adrenal. For those who are in medical school here, want to remember, we call it, I abbreviate it GFR. GFR. That's the granulosa, the follicularis, the R stands for the reticularis. The inner you go, the sweeter it becomes, okay? So sex hormones are produced in the inner cortex. So that's where they are produced. And those hormones include estradiol, testosterone. And that is where the new androgen blockers come in. The abiraterone, the enzalutamide, the apalaterone, and Nubeqa. Those drugs come in and they help block other sources of testosterone production, and they help the cancer not to grow anymore. So we have that. Now in Cameroon and in Europe too, it's still approved. In America, it's illegal to do an oophorectomy for treating. It's not, you don't do it. In Europe, you can still do it, even in France, even in the UK, it's approved for patients who want to do it. It's just that psychologically, a lot of men don't tolerate it very well, that they got castrated. But if it's for the sake of helping you with the prostate cancer, now Lupron in Cameroon is expensive. You need to get a shot every 3 months or every 6 months. I prefer the 6 months and the 3 months, they are the same price. So you can get access to Lupron at Noble Pharmacy in the Northwest region. Bingo has it. Multiple places do have access to androgen deprivation therapy in Cameroon. They are not just getting the reference for the right patient. So we need to refer our patients there and make sure they have access to it. So I think the second part of the question is looking at other treatments, which I talked about. There are other treatments. Abiraterone is found in Cameroon, it's approved. Docetaxel, all oncologists in Cameroon, is an old drug. It's one of the oldest chemotherapies, okay? Docetaxel is the oldest, one of the oldest chemotherapies. All oncologists in their right minds are supposed to know how to give docetaxel. Now, you should, in the first line, someone comes in with meds to the bones and everywhere, and they have a good functional status in Cameroon, you should give them docetaxel, just 6 cycles. You give them abiraterone, which is generic now, and you place them on Lupron every 6 months. That's how you treat them. I have a patient that we just started treating in the regional hospital. We gave him just 1 shot of Lupron. He's doing fine. He got discharged. The guy who came in, who was anemic and was getting transfusion every week, though I had a lot of pushback before he ever got that treatment, that 1 drop. But he's doing fine. The sister called me in the US just a few weeks ago, who used to be a general supervisor in that hospital. She was very thankful. She thought the brother was going to die and not make it. So this can be treated in Cameroon.
Yeah, I think it's very interesting to see that there is option for metastatic cancer. But there is a question in the chat, and I'm really interested to hear your opinion about it. It is regarding overtreatment. How do you actually separate or differentiate benign prostate hypertrophy from misdiagnosis of prostate cancer? And my personal question is also, what are the dangers to overtreat those who are misdiagnosed?
So majority of the time, PSA, high PSA less than 10, you need, and which is not rising over time. So what I would advise is PSA between 6 and 10, you need to refer to a urologist. Once the urologist sees the patient, he's going to do a digital exam, he's going to do an ultrasound of the prostate. Most of the time with benign prostate hypertrophy, just with an ultrasound, they'll be able to tell you that you have benign prostate hypertrophy. Most patients with benign prostate hypertrophy present with urological symptoms. Prostate cancers do not. Urological symptoms, because the whole prostate is big and is blocking the tract, the ureters. So they present with urological problem, hesitancy, dripping, incontinence, all those things occur with benign prostate hypertrophy more. And usually just by giving them medication, trial of treatment with tamsulosin, and their symptoms get better. And the PSA stays the same. Usually PSA are not even high, but the PSAs don't get above 10. Once your PSA gets above 10, you need a urologist to examine you and do a biopsy. The urologist needs to do a biopsy and for us to make sure that there is no prostate cancer. In places like here, I would do an MRI of the prostate because I have access to it. I'm just going to misuse the MRI. I would do an MRI of the prostate. The MRI of the prostate is going to tell me there's a lesion there or not, and then we stop the argument. But you don't have that luxury back home in Cameroon. That's where it's a multidisciplinary team. Don't sit in your chair as the GP and think you're the star in this show. Send them to the urologist to make sure that these patients don't have it. Your second question is more important. How do we make sure we don't overtreat even those who have prostate cancer? That's the more important one. As I told you in my presentation, those will listen. Not every prostate cancer patient needs treatment, and that's a fact. So there are patients who will have prostate cancer. They would have it for 20 years. Like one of my patients that just saw me yesterday. That was his 31st anniversary. He's 81. He needs treatment now, but he did not need treatment for 31 years. Since he was diagnosed, you can't believe this, but he was very low risk. So those who come in with a Gleason score of 3+3, PSA of about 6, not rising. The next 10 years, it has just risen to 7. The next 10 years, risen to 8. He has prostate cancer, but he's going to die from something else, given his life expectancy. Right now, his cancer became a little bit more aggressive. He has oligometastatic disease. I'm just going to radiate the prostate. I spoke to the radiation oncologist. We'll radiate the prostate, radiate the oligometastatic disease, give him Lupron for about 1 year and stop. He's 81. I think he's going to die of something else. I don't want to overtreat him too. I want him to have a good mind. His mindset now is that he wants treatment, so I want to make him satisfied. But I also want not to put him on Lupron forever or add additional androgen therapy that is going to cause him more side effects. So I'm thinking about quality of life. So there are a lot of patients that you need the urologist to do the biopsy. You need the pathologist to tell us what the Gleason score is. We need to stage the patient so that we realize that those with very low risk disease, we are not going to treat you. That is actually about 20% of prostate cancer patients. That's why I say there are a lot of people walking around with prostate cancer that they don't even know. There are a lot of people who are assuming they have benign prostate hypertrophy while they have prostate cancer. They don't know. They don't need treatment. They are not even supposed to need, but we should be able to identify the ones who need it. The sad thing is that Black people tend to have more aggressive disease. You find more white patients with very low risk disease compared to our Black population.
Thank you.
Mona, are there specific, I guess my curiosity is biomarkers that would distinguish a benign prostate hyperplasia or hypertrophy from a prostate cancer. Are we at a stage where we've been able to identify very specific markers that would distinguish both?
So we don't have genetic markers. Can you guys hear me?
Yes.
Yeah, we don't have genetic markers, but we have other things. So usually what we call very low risk prostate cancer is anyone who has a T1C disease. So it depends, the nodule is very small. Who has a grade 1, which means that he has a Gleason score of 3+3. Who has a PSA which is less than 10. I didn't want to go into this because that's more of oncology. Who has fewer than 3 prostate biopsy fragments that were positive and less than 50% of cancer in each fragment. And who has a prostate density less than 0.15. Those patients are considered very low risk. And those patients may never get to need treatment, may never. So in prostate cancer, really, is one of those few cancers. I always joke about it with my patients. I tell my patients this all the time because I see them, we have to discuss treatment. You may be with your friends. In the US, people discuss, they go into the internet. You may be with your friend who tells me, oh, my doctor gave me docetaxel, abiraterone, or enzalutamide plus Lupron. And then the other guy says, my doctor gave me nothing. He told me to go have a vacation and come back and see him in 1 year. That's what I tell some of my patients. And the reason is because we classify these groups as so important for the urologists: very low risk, intermediate risk, high risk, and very high risk. And once we classify them that way, we treat them that way too. Very low risk, intermediate risk, intermediate high, intermediate low, and then high risk and very high risk. Just that majority of I have not done. Sadly, I worked in Cameroon. I worked as a GP in Cameroon for 2 years. Then I was in charge of a district hospital, but I did clinical pathology 4 years, but I did not have time to really think about cancers this way, the way I'm thinking about them now. So I can't really tell you guys because I was part of the group that was not screening. But what I will tell you is that here in the US, Black patients, It's just something, I see a Black patient come into my office and they said, oh, prostate. I just know that it's going to be metastatic. It's rarely localized. There are also determinants of health and their access to health, which some people don't want to agree, but there are determinants of health and access to health that could play a big part. But it's time for us to study our own people. Let's do research in people that look like us and figure out what is going on. I'm just saying Africans is also very, being very general. Majority of Blacks who are in the US came from West Africa and Central Africa. They didn't come from East Africa. They didn't come from South Africa. So those Blacks in the US look like us in West Africa. Just know that. They don't look like East Africans. They are not genetic variations. They're actually West Africans. Blacks that went through slave trade, that's what people have never known. The characteristics of Blacks in the US and in Brazil and all those Blacks they talk about, they're actually West and Central Africans. They are not East Africans, they are not South Africans, they're actually West and Central Africans.
Thank you. Dr. Mono, I wonder, you mentioned that collaboration is very important to really tackle, address this disease. So I wonder if you can talk about the collaboration, the need for collaboration for other provider beyond just the medical provider. Can you give us an example how important, for example, like the social workers or any other supportive provider in the supportive care realm is to your practice and also to your patient?
Very important question. I'll give you a scenario how I work in my cancer center so you understand the importance of the pharmacists, like you're a pharmacist, everyone. So how does a cancer patient reach me in the first place? So a urologist sees this guy who comes in with dysuria, and he's been treating him for benign prostate hypertrophy, and he decides that, okay, it's time for us, the PSA is rising, it was 6, now it's 10. The urologist doesn't contact me yet. Let's get a biopsy. He gives him in the office, he gets an ultrasound guided biopsy. And he does that, and he gets that the patient has a Gleason of, let's say, of 5 plus 5, which is 10. What he does next is he's been talking with the pathologist. The pathologist is already involved, but the medical oncologist, which is myself, is not yet involved. But the pathologist is involved. The urologist is involved. Now he gets what we call a nurse navigator in the US. The nurse navigators, they are trained to help these patients navigate the system, which can be complex. These are oncology nurses that know the guidelines. They are trained to help navigate. The nurse navigator contacts me with a text message on Epic. Dr. Kenny, I have this patient here who is here. Urologist referred him that you should start him on Lupron or consider this. I see the text and I asked her, as a medical oncologist, have we done metastatic workup? Given that his PSA is now 23. The nurse navigator says no. I said, get me a pelvic MRI and a PET scan for me to rule out metastatic disease. Should I even consider sending him to radiation oncologist, or should I even send him to a uro-oncologist for prostatectomy? That's how it works in the US. Now, he gets a PET scan and I see, luckily, he has no disease anywhere else. I'm just giving a good scenario. And his MRI of the pelvis is going to help the radiation oncologist, shows that he has disease in the prostate, moving along the seminal vesicle and all of that. The next thing I do, I make an appointment with him in the office and I refer him also to the radiation oncologist. The nurse navigator navigates him to the radiation oncologist, makes an appointment. Then when he comes and sees me, if he has not yet met the people that are important in my team, let's say, for example, he had metastatic disease. Let me make it now a bit complex. I get to, and he's having bone pain, I get to involve the palliative care team. I give him a referral for palliative care. He's underweight. He has not been eating well. He has anorexia secondary to malignancy. I give him referral to nutritionist. Oncology nutritionist gets to see him. 3, I want to give him chemotherapy. I talk to my oncology pharmacist and we decide that we're going to start him on a dose reduction because he has chronic kidney disease. His kidneys are failing also. But I want to give him chemotherapy. So I get the oncology pharmacist. We adjust the doses of all the medications I'm going to give him. I'll be starting him on Lupron. I'll be starting him on docetaxel. I'll be starting him on Nubeca. All those treatments, I need to decrease their doses. The oncology pharmacy helps me with that. And we set up this patient for treatment. Now, the social worker realized that he cannot pay his bills. His co-pay is $1,000, and Bill Gates has this funding that he's giving, or there are other fundings. We get the social workers to get involved. He's living in a trailer. He doesn't even have a home. And now we have to start getting a home for him close to the radiation area where he's going to get radiation to his bones. So you get to see that this is not just a one-man game plan. It's a team sport. And the team sport involves all these doctors that have helped, including the radiologists to interpret these scans, including the radiation therapists, including in the radiation department itself, you have multiple people who will be involved in actually planning his care. You cannot have a radiation oncology department without a dosimetrist, without a physicist, like who Dr. Sidney Taze is a physicist. You will not have him without, in my practice, you have the nurse practitioners, you have the physician assistants, they will all help us. You have the oncology nurses who give the medication. It's a team sport. And in Cameroon, we have the habit of, like now, we have a habit of training, opening 100 medical schools, and we don't even have a school to train medical physicists. Neither do we have a school to train oncology nurses properly. So we look at, we're too narrow-minded, and we don't look at things in a holistic manner and understand that this is not, the doctor doesn't work alone. And you don't sit alone in your office and think you can treat cancer. You don't do that. So, Sandrine, did I answer the question a little bit well?
Yes, I think this was well covered. If you look at the US and Canada and other countries in the West, I think if we can think, and this maybe is a question for the audience, Dr. Samuel, who has experience in the field back home, how might we, or how can we actually tap into this model? Because the nurse navigator, I think that's an interesting model. In Cameroon, we have community workers, and we do also have the family member, quite frankly, acting as these navigators already by default. How can we empower the local resources that you have, in your experience, or the one that I just cited, meaning the family members and the have community workers? How can we empower them to be those I would say connecting points with the existing physicians, providers, and have a what I call a patient-centric care approach?
Thank you very much. I think as Dr. Mono was talking, I just kept thinking sometimes it comes down to the structure right now. We are still piecing it out, especially in local areas. Maybe when you get to Yaoundé, Douala, and others, it is a little bit better. I picked up, for example, you have to deal with the challenges of education. You have to deal with the challenges of actually the financial part of it. The referral, one thing that I noticed, I had a patient that we were referring to regional hospital in Bamenda. And first of all, the family, they told us, well, we don't even have the means. Number two, when we get there, it takes longer to even see a specialist, because even if you have one person who is available, in the local areas where we are, yes, we do have community health workers. We are far from even getting closer to when you talk of a multidisciplinary team. But what we have been doing in our area, we have the district hospital, we have also another sister hospital, the St. John. We are trying to work together. And working together is trying to create a system where we try to know in the situation where if you have a patient talking about even cancer, the family support is number one. The family support is number one. So what we have been trying to do is to get the family together the general practitioner, they start talking to them. And sometimes just because of the means, it becomes very difficult. But having the family together, which it comes down to the education, where it's still at an early stage, where the education is still very, very crucial. Like Dr. Mono was saying, sometimes we just give up because we don't even know what is out there. And because they know that chemotherapy or radiation is very expensive, or even having access to go to the city, they might not even have any family members. So you as a general practitioner that you are sending them to the city or to Bamenda, they always say, we have never even been there. Where are we going to go with? And now you have to start making the arrangement of calling the director at the regional hospital in Bamenda, just trying to get, there was one time I was calling the director at the regional hospital and they were out there in the southwest. They're not even in Bamenda. So now he's like, oh, tomorrow I will get in touch with the person on the ground. So there is a lot of challenges on the ground when it comes to even talking about navigating the system. And sometimes they will be like, can we just stay here with you? So it is something that is, I will not even say it is even in the infancy stage for us, but it's interesting when we get all this discussion, looking how we can actually come together to put resources together. That is really what I'm looking. I mean, I'm always excited when we have this discussion. So thank you very much, Dr. Sandrine.
Thank you for sharing. We have a question from Dr. Aaron, and I think we might head up for the closing remark after that.
Hello, are you getting me?
Yes, we
Yes.
can get you.
Yeah. Hi, Muno.
Hi.
So that you see my face a little bit.
Oh, Irwan.
Yeah, it's I'm the one. It's just that I'm with the baby here. She's not allowing me to hold my phone very well. It's not really a question, maybe a contribution. Why? Because that very last questions you really answered about how to navigate in here. I think is one of the problem we have, and that we are happy that every time at the town hall, there are a lot of us who are teachers. I think for a long time we have been teaching just medicine, book medicine, but that's why I say it. Nowadays we have this particular. Now today we know that we can, us from the field, these kind of problems we can raise them so that the way of teaching students will be different. We have to teach them how to navigate, because here is not simple. We don't have a navigator. My practice usually, at a certain time, I mean, when a patient is above usually 40-50, I usually ask him to come to the hospital every time with one member of the family, because I always know that sometimes, especially men, he will come alone and we think that he can deal everything alone. Meanwhile, it's not going to be that easy. Not only for money, sometimes he doesn't have enough money to pay, so that the whole family should gather to give some money. Then for me, the person of the family is very important for us, and we have to teach, as medical personnel, we have to teach that member of the family who will really do the navigation. Now, the second thing is that I hope the big centers, maybe like Entini, for Douala here, L'Hôpital Général, they should do a little more of advertise about their different services. So that you see, for example, this month we are talking a lot about cancers. You will see maybe like Entini will come up on stage, maybe on a radio, TV, and discuss about the different things that they can do, which is good. But sometimes it's like their target is only the patients. As the big hospital, their target should be all the district hospital, all the medical centers, all the doctors and nurses who are those in the medical centers, the district hospital, who actually refers the patient to them. So you can imagine sometimes I want to refer a patient to like an engineer in a service, but I don't even have the number of one doctor of the service. Should I just call my other friend who is in rheumatology? Meanwhile, I want to send the patient to see maybe an oncologist or something like that. So I think like engineer is not making enough does not advertise their services, their numbers where we can call for those services to the other medical professionals who are working as primary care physicians. Me, I'm mostly primary care. Patient usually comes to me first point. And then when I have a problem, I say, okay, let me send you to Hospital General, or let me send you to La Quintini because this case, you have to do this, or I have to take care of you with this and this. And sometimes if I don't have the personal number of a doctor that I know, and I can call him, usually the patient will not be feeling, and you know, we are Africans. Africans, we always has a feeling that the system is not working enough. People always feel like it's person to person. You need to know somebody so the patient is more confident when I personally know the doctor I'm sending him to, because he has the feeling like he's my patient, he belongs to me, and then I'm sending him to one of my friends so that my friend is going to take him the way I'm taking him. The system is not organized for him to understand that they will just take good care of him. So I believe that we have to teach them to teach this thing to the different in the faculty of medicine, in the school of nursing, and we have to teach the hospitals to really do that, especially the referral hospitals. They have to learn how to come and advertise themselves to the medical professionals of the primary point of care of the different patients. That's what I wanted to add.
Yeah, so just reflecting on what Ewan said, and yeah, Ewan is a friend and a classmate. He's a surgeon in Douala. He owns his private practice. And you may not, those in the town hall may not know, but I discuss oncology cases with Ewan at least once a week. We talk about different cases and we go through the dilemma of all what is happening in Cameroon together. So we're classmates, and he did his surgical training in Ghana. So it's a pleasure always having you here, Erwan. And it's very important. What Erwan raised a big problem, and I also find myself, I was in Cameroon. How do I even refer a patient to the oncology department in l'Hôpital Général? He just made me think about that question. Like, let's say I want to send a patient, why just send the patient to walk into the doors? Is there a phone number? Is there a system in place? Is it advertised? Do the doctors know it very well? Can the doctors have access to radiation oncology? I just need to call my son, Anne, who is there, who is my classmate, who is a radiation oncologist? Is that all? Everyone can call all of them. He knows everyone there, but is that the right way it's supposed to be? How does the doctor in Furawa refer the patient and the patient is seen? That's really, I think that's Dr. Polo, that should be a thing we can discuss in one of the town halls about referrals and counter referrals. How are they even structured in Cameroon? And is it that they are not being done because there is no systematic way of doing it? It just made me think about what Erwan just said right now. Before we close, I don't know if these people, I've seen some people online, they have had some personal experience. I don't know if they want to share or talk about anything. I see Dr. Joyce Foyam, who is an internist here in the US. I don't know if she has a word to say about prostate cancer and any experience that she had or have had, which not making it personal, but I just want to know if Joyce has something to share or she's at work. I don't know. Or she's just being a listener. Do you want to unmute and say something, Joyce? So I think Joyce may be busy, but it's one of those things that we both of us had an experience in Cameroon with a prostate patient, and it was very traumatizing. She's an internist. She knows what is supposed to be done. But
hello.
Yeah, hello, Joyce. Yeah, please.
Dr. Mono, I'm sorry. I had to go to an area where I could talk. I have kids around. I'm sorry, guys.
Okay, no, I understand, please.
Yeah, so like Dr. Mono was saying, my uncle had back pain like most elderly black men back in Cameroon. And he had been complaining about his pain.
Oh, we just lost you a little bit. We're hearing you. We just lost you a minute.
Can you hear me?
Yes, perfectly.
All right. So we found out that he had prostate cancer with mets to the bone. He had told us he was seeing a urologist, and we knew that he was getting like the right care. But then he called me on this day and he was expressing that his urologist had told him that a prostatectomy was going to be like the solution to his problem. It got us really concerned, at least.
We're kind of losing Joyce with this very interesting story. So
Hello?
yes,
Can you guys hear me?
yes, we can get you now. Oh.
Well, I think we can close, maybe take it to the parking lot, maybe after.
No, we can take this to the parking lot,
Yeah.
but the end point of it is that Joyce is
Muna, so
yes.
yeah, before you guys go to the parking lot, this is Chobufo.
Yes, Chobufo.
Yeah.
Oh, this is Dr. Dita Chobufo. He's a cardiologist here in the US.
So thank you. You know, I listened to Iran and I remember Iran, but he brought up a very big problem. And I think it's important because just this week I got called by one of my friends. The mother was hospitalized in Boya. They had hospitalized this mother for pneumonia. They did a CT scan. In fact, they hospitalized the mother for pneumonia. And then somebody thought it was heart failure. They called one of my colleagues who is a cardiologist. So he went and saw the patient, examined the patient and said, oh, there's a lump mass here. Let's get a CT scan. They got a CT scan. Then ultimately, the radiologist said, oh, I see a lesion, I see adenopathies and others in the lungs. This is probably metastasis to the lungs. No. Then they called me up and they were like, they don't know what to do. And I said, well, she was on oxygen. I think the most thing is get the acute stuff done, then we'll refer her somewhere. But I didn't know where to send this lady. Honestly, I didn't know anywhere to send this lady. They said, oh, they are called on the guy maybe comes around once a week. So when I picked the phone, they send the records to me. I said, okay, send to me the number of the doctor. When they sent this is the number of my classmate in case. So I called him up. I said, you are taking care of my mom. What's going on? He narrated the story to me. The radiologist who read the CT is my classmate as well. So things just worked out for me. But again, I still didn't know who to send this lady to. I ultimately ended up calling one of my friends who is a medical physicist in Cameroon Oncology Center in Douala, just to make sure I had a connection before I send this patient anywhere. Again, it comes down to the problem of how do you even send these patients? Here I am, a medical guy, and I had somebody with probably metastatic disease, and I did not even know how to navigate the system. I didn't have any doctor I knew. So I ultimately ended up getting a medical physicist who is not even a doctor, just to try and say, when this patient comes into the system, please go ahead and hook up this patient for somebody to see. So I'm just adding my voice to say, yes, we need channels on how do people even go around in the system, because that is a big problem. And if I didn't tell them, okay, I've spoken to somebody, please go, this person is going to guide you, I can guarantee you they'll most likely not go. And even just saying to Cameroon Oncology Center, I don't even know what services they offer. It's just from the name, and I'm like, okay, I'm hoping that when they go there by the name of this, they should be able to address this patient. Moving all the way from Boya to Douala, do we even have these services in Boya or in the Southwest? Maybe, but I don't know. So this is, again, how things are going. Anyway, I just wanted to share that. But I think I'm here. Joyce was unable to talk on her phone. She wants to use my phone and talk. So I'll let her talk.
That's wonderful. Let's hear from Joyce, Brian, before we close the session.
All right, okay. So this is really about same thing. We really don't have people to send our patients to. We had this guy who came in and had a metastasized cancer, and the only reliable person we had was going to do what we all know was not right by what should really be done. We ultimately got to Dr. Mono, who helped us, referred us to Bingo Hospital, and where he's now getting treatment. His PSA is actually like undetectable right now. He's doing really well with his Luprolide and the rest of his therapy. That said, I think this information is extremely important for us to all know. Prostatectomy, or just taking out the primary lesion, is never the ultimate treatment for a cancer. And we really all have to know that. It's just alarming that a urologist in one of our best hospitals would like want to take out a patient's prostate just for monetary reasons, and like really doesn't care much about the patient. Thank you, Dr. Mona. Thank you for all the help you're like giving, the services you're offering to us who don't have people in Cameroon, and even the information you're helping the doctors back in Cameroon have. I think as I don't know how much you know or the impact you imagine this is having on the community, but it is having a great impact. We really appreciate you for all of this help you're giving us. That said, I just want us all to like just read up on like the various pathologies we have. There's a lot of information online on everything. We all receive patients, and like we're all doctors. We get like lost about what to do, but then there's guideline, like evidence-based information everywhere, which we can always reach, and we can also reach out to colleagues who would help us. I don't want us to like go on treating a patient without having like a good idea of what's really happening. Again, thank you all. I'm not sure I'm very frequent on this forum. I really would have loved to be, but time constraint and everything doesn't permit me to. But I hope this goes a long way to help everybody around here just like know what's right to do by our patients.
Yeah. So just a little reflection. Thank you. Thank you very much, Dr. Joyce Foyong Dita.
I think I lost you, Dr. Mono. I think the sound again.
Yeah. We still cannot hear you.
Can you guys hear me now?
Yes.
Oh, good. So it looks like I have. So I just wanted to say a big shout out and thank you to Dr. Foyong, Joyce Dita, and also to Dr. Chobofo for the contributions which they made. And Joyce is an internist. She's a sister to me. And we've had a lot of cases. And Chobofo is also a brother. I've known him since medical school. So you can imagine he knows Cameroon very well. And if he has difficulties navigating.
We lost you. We cannot hear you.
Oh, no, thanks. I think we can take this for the parking lot. I just wanted us to close since we are almost at the hour already. Yep. Can you hear us?
Just my closing remarks. Know Cameroon very well, but we have difficulties in navigating Cameroon that we know well. I'm feeling very sad for the patient he sent. Just recently reflecting on the patient's case. How do we get a biopsy? Are we going to be able to get a safe biopsy on this guy, on this Mami, to know what kind of lung cancer she has? Is it small cell? Is it adenocarcinoma? Is it squamous cell cancer? What is it? Because treatment is going to depend on that. Are we going to be able to get a biopsy? And are we going to be able to get good pathology to actually stage them? That's why lung cancer in Cameroon is practically zero, because no one does biopsy. So you cannot actually report something that you don't have. Do we have a good pulmonologist who can do an e-bus? So these are all reflections that are coming. His case actually has brought more challenges to my reflection today than they would have actually brought, because it's a difficult cancer to navigate in Cameroon. Now, going back to the highlights of the month, which is both prostate cancer, which
Still cannot hear you.
Oh, sorry. Our goal for this presentation was to make sure that people can actually understand that we need multidisciplinary approach. Our next month, we'll be talking about breast cancer. We'll have Dr. Taze Sydney, who is going to tell us about the wonderful things they're doing in terms of breast cancer in Cameroon. So thank you very much. Thank you, Brian. Thank you, Dr. Polo, for the moderation, and over to you.
Yeah, thanks a lot, Mono, and thanks a lot for talking about this very important subject. I don't know if Dr. Polo, you have any closing remarks before we close.
Thank you. I would just want to thank you. Merci à tout le monde d'avoir participé. C'est une discussion très intéressante. Ce qu'on retient, c'est qu'il y a des traitements pour le cancer de la prostate, mais surtout, tous les patients n'ont pas besoin d'être traités. Il faut un dépistage approprié. On a parlé ici du facteur, du gold standard. Il faut regarder le niveau de PSA en bas de 10 pour classifier ces patients-là. C'est très important, la classification. Nous avons également parlé de référence, de référencement, qui est toujours un problème entre les médecins qui se trouvent dans les hôpitaux centraux, Yaoundé, Douala, et ceux qui se trouvent en périphérie, qui est un problème qui n'est pas résolu, mais un problème à qui il faut s'attaquer pour le cancer de la prostate et probablement pour bien d'autres pathologies. Ce qu'on retient, c'est que le traitement du cancer de la prostate au Cameroun ou ailleurs est important. Il est important de l'approcher dans une approche multidisciplinaire qui implique les médecins, mais aussi tout le support social pour le bien du patient. Dr. Mono a parlé également à la toute fin de sa présentation de l'importance de l'investissement. Et moi, je vais finir là-dessus à appeler toutes les personnes dans la diaspora, toutes les personnes qui se trouvent sur place pour regarder qu'est-ce qu'on peut faire. Chacun a besoin des patients du cancer de la prostate. Il y a un besoin qui a été soulevé encore et encore, le référencement. Comment chacun de nous ici peut servir d'acteur ou un moteur de référencement. Je pense que ça, c'est dans notre cours. On a très bien vu un exemple qui a été cité dans le dernier commentaire, ceux qui connaissaient Dr. Mono et qui ont connecté avec des personnes localement. Je pense que chacun de nous peut le faire, puisqu'on connaît ce forum. Si on a des cas comme ça, on pourrait déjà, à travers ce forum, utiliser les ponts qui ont été bâtis pour servir. Je vous remercie tous. La prochaine session sera sur le cancer du sein. Nous aurons Dr. Tazé comme présentateur et nous allons poursuivre avec le parking lot. Merci.
Yeah, thanks a lot, Dr. Mono, Dr. Polo, for that very comprehensive summary. Any closing remarks, Dr. Mono? Then we can close the session for today.
Oh. This has been a difficult session with my volume. I don't know what's happening, but it's never happened before. No, I just want to thank everyone for their time. And you guys know the town hall is, for those who are here who are new, and those who come in from time to time. If you have some important subject that you want us to discuss back home in Cameroon, don't hesitate. We are always looking for moderators to join our team. We are also looking for speakers, but we vet speakers. That's the difference. So Brian vets everyone who comes in here. So we vet speakers. We're looking for speakers, but we vet speakers so that we have the most appropriate speakers that we can talk about a topic that you feel is important in Cameroon and a topic that we can change lives in Cameroon. It can be a speaker, a Cameroonian in the diaspora, or a Cameroonian back home. Cancer is a reality. Prostate cancer is the most common cancer among men. There is a lot we can do. Breast cancer is the most common cancer among women. It has a lot of traction when compared to prostate cancer. So in 2 weeks, join us. Let's celebrate those who are doing wonderful things in terms of prostate cancer. We're not going to be giving you lectures. We have a lot of wonderful Cameroonians doing a lot concerning prostate cancer. Our goal is trying to celebrate them and showcase what they have been doing. There are multiple people. There is the Angel Foundation, which is doing a march today in Atlanta. They're always doing things back home. There is Clear Radiology, which is presently doing free screenings in Boya for prostate cancer. They have imaging. They're doing a lot. There are multiple other foundations back home in the diaspora, a lot concentrated on prostate cancer. Maybe we'll convince some of them to concentrate on prostate too in the future. So let's get them on for celebration. I'll be doing a 2-series lecture. It's going to be the week of the 26th, which is geared towards oncologists and geared towards physicians, nurse practitioners, nurses, and anyone who takes care of breast cancer, just to update them about what the guidelines are. So Brian, thank you very much for your time. Sandrine, thanks for your time. You have made a wonderful change to our platform already. We're becoming more bilingual and truly representing Cameroon. So thank you for all what you do. And I just want to thank everyone who sacrificed their Saturday to join us here. Stay tuned for the parking lot. We'll have 15 minutes in the parking lot, and you're free to say whatever you like because we're not going to actually broadcast that.